So postmenopausal woman, N0, 68-year-old woman. She's a retired lawyer. Clinical features: in December 21, she had right side breast cancer, no special type, lumpectomy with sentinel, 9 millimeter tumor, no involved lymph nodes, lymph node negative, G2, ER, PR 100% and PR 50%, HER2 negative, and the Ki67 is 40%. She had breast surgery, she had radiotherapy to the right breast. So, what will be your decision when this retired lawyer is coming to your office and asking you chemotherapy followed by endocrine therapy alone, not sure, or you need a gene expression? Okay, please vote now. And the result is you need a multi-gene expression assay. Perfect. So let's go for the multi-gene assay. Okay, now the patient has an EP-CLIN risk score of 4.1, which is by definition high risk. The likelihood of distant recurrence within years 0 to 10 is 19%. The absolute chemotherapy benefit at 10 years is 8%. And the likelihood of late distance recurrence within the years 5 to 15, so after 5 years of endocrine treatment, is 15%. And obviously, with this in hand, I think, and it doesn't have to be a retired lawyer for every patient, we can explain it quite good, what the individual risk is, what the absolute benefit is, obviously the side effects, and then how to make patient the decision much easier. Clinical information for an EP-CLIN risk of 4.1. On the left side, the 10-year likelihood of distance recurrence. Now, this is what is of most interest for the patient. Obviously, the local regional recurrence is also important, but the patient wants to know, if I'm going to have metastasis, then I know that I'm going to die of cancer. So please tell me what my risk is. So 10-year likelihood of distant recurrence, as you see here. So this is something which is very, very reassuring, that the EndoPredict clinical risk is something which is a linear factor, is a linear argument to talk to the patient. And you don't have to finish medical school to understand this line, because obviously you see if you are below that threshold, then having a risk score of 3.2 or something, then you're fine, you're okay. And the higher the risk is, the higher the risk of metastasis is. And obviously from there also the therapeutic decision is going to be made with an absolute chemotherapy benefit at 10 years, which is, again, the higher the risk, the better the increases, which is telling us something about the predictive benefit of this test, and also the likelihood of late recurrences, which is also very important piece of information, because you can imagine if this patient comes to us and she's 60-something years old and she has a life expectancy of at least, let's say, 25, 30 years, then she knows, I don't want to know just my short-term follow-up prognosis. I want to know, how am I going to do for the next 15, 20 years? And this is a very important piece of information. And the next one. Okay, so please decide what would be now your treatment decision, considering what you have just seen. Is it chemotherapy followed by endocrine therapy, or is it endocrine therapy alone? Please vote now. For those of you who voted 3 out of 24, endocrine therapy alone, I am sure you must have any reasons, which maybe we can discuss at the end of this presentation. But it's quite good splitting. But again, the majority, absolute majority, is for talking to the patient about chemotherapy. Okay, so systemic therapy was decided with the patient, not just for the patient. Adjuvant chemo with 4 times CC and 12 paclitaxel. We can also give, I talked to the patient also, we can also give an anthracycline-free regimen. And obviously, because she also had in her mind that there is some additional risk after year 5 to go for another aromatase inhibitor, and probably even to go for a longer treatment and just do not stop at 5 years. Okay, now at least for the follow-up until now, she's doing fine. In postmenopausal patients, now this is a quite large database. You see here thousands of patients from ABCSG 6 and 8, from Philippides, and also from Dr. Booth, and on the right side from the TransAttack study. Again, same story again, majority low risk, long-term, just a few patients with metastasis, and those patients who have EndoPredict high risk have higher risk of metastasis, and also in those patients from the TransAttack study with 20% risk of metastasis. And again, it's a minority, but it's important to define and detect this minority, less than 30% of the patients, in order to tell them what to do. So this patient here, she was from the so-called minority, but the multi-gene assay is helping us to talk to the patient, to give exact numbers, and not just, oh, I have the opinion of doing this and I have the opinion to doing that. Because especially this lawyer, she said, oh, I want to see the clear numbers. If you give me the clear numbers, then I will make a clear decision. So again, this is quite a very nice piece of information. And again, from the curve you see here with a 10-year risk of distant recurrence, and again, it's a linear increase of the risk with the increasing risk in the EpiClean. So this is again reassuring that the higher the risk, the higher the benefit from chemotherapy. Obviously, a very low risk or a low risk patient do not have any benefit from chemotherapy, just the side effects. And that is again something really extremely important about multi-gene assay.